Welcome to Bookfulness, the deep dive designed to make even the densest anatomical text feel like a thrilling exploration. This is episode 32.
That's right.
And if you've been with us, you know we've spent our last few deep dives really firmly grounded in the complex biomechanics of movement. We walked ourselves step by step through the joints and muscle groups of the lower limb.
Yeah, we really did. We navigated the forces for stable gait, how things can go wrong,
Yeah.
hip fractures, muscle firing patterns in the leg. It was all about stability, propulsion.
Right. But today we are making a monumental pivot, I guess you could say. We are launching superiorly, shifting our focus from the feet and knees all the way up to the command center, the head. Our source, as always, is Clinically Oriented Anatomy, 8th edition, and we're opening chapter 8, the head.
And our mission today is pretty ambitious. We're drilling down into the bony architecture itself, the cranium. We'll be charting the structures you see from the outside, mapping the 3 critical internal cranial fossa, these sort of shelves inside, and then, really importantly, immediately translating that anatomy into clinical reality.
How so?
By exploring how this bony fortress protects the brain and, the various ways it can fail when faced with trauma. We're covering original book pages 1286 right through to 1318.
Okay, quite a bit of ground to cover then. Let's unpack this starting with the fundamental definition. When you look at the skull, it's not just one single bone, is it? The source material immediately sets up 2 major divisions.
That's correct. 2 functional architectural divisions right from page 1287. These are the neurocranium and the viscerocranium.
A neurocranium and viscerocranium. Break those down for us.
So the neurocranium, think of it as the brain case. It's the large protective bony enclosure for the brain itself, its meningeal coverings, and also the very proximal parts of the cranial nerves and blood vessels. It's essentially the helmet.
Got it. The helmet and the viscerocranium.
The viscerocranium, in contrast, that's the facial skeleton. All the bones making up the structures of your face, including the orbits, the eye sockets, and the jaws.
And the most striking thing about these two, especially looking at an adult skull, is just how different they are in size. Figure 8.1 in the text really shows it.
It really does. In adults, the volume of the neurocranium is approximately double that of the viscerocranium. That 2-to-1 ratio is quite significant.
Double the volume. Why is that important?
Well, it's not just a fun fact. It really highlights the evolutionary and biological priority, protecting the brain and those special sensory organs. That ratio is also one of the easiest ways visually to distinguish an adult skull from, say, a newborn skull.
How so?
In a neonate, the cranium is disproportionately large compared to the face. The facial skeleton is much smaller because structures like the maxillae, the upper jaw, and the paranasal sinuses, they're still pretty rudimentary at birth.
Okay, so the neurocranium is large and dominant in the adult. Let's start our external tour then. Looking at the anterior aspect, the face. Original page 1293.
Right. This frontal view is a landscape defined mainly by the frontal bone up top, the zygomatic bones, your cheekbones laterally, the small nasal bones in the middle, and maxillae, forming the upper jaw.
And this area isn't just about structure, it's packed with important nerve pathways, isn't it?
Absolutely. It's defined by the needs of sensation and breathing. Anatomically, it's a crucial map for clinicians because it's just densely populated with sensory nerve exit points. We need to immediately identify 3 major these are holes, basically, that let major sensory nerves of the face emerge onto the skin.
Okay, 3 keyholes. And this is where it gets really clinically relevant, especially for things like numbing the face for procedures, regional anesthesia.
Exactly. So starting superiorly, we have the supraorbital notch, or foramen. Sometimes it's full hole, sometimes just a notch. This transmits the supraorbital nerve, which is a branch of the 1st division of the trigeminal nerve, CNV1.
Okay, top 1, supraorbital.
Then, a bit lower, embedded in the maxilla, right under the orbit, is the infraorbital foramen. This carries the infraorbital nerve, a branch from the 2nd division, CNV2.
Infraorbital. Got it.
And finally, down on the mandible, the lower jaw, we find the mental foramen. This transmits the mental nerve, which branches off the 3rd division, CNV3.
Supraorbital, infraorbital, mental. And what's really fascinating, and the book points this out with figure 8.3, is their alignment.
Yes. It's incredibly convenient anatomically. These 3 exit points often lie in a near-perfect vertical line down the face. This isn't just random chance.
So what's the significance of that vertical line?
It's the clinician's roadmap, essentially. It allows a practitioner to quickly visualize the path of these major sensory nerves to achieve really targeted regional anesthesia for facial procedures. If you need to numb, say, the upper front teeth or repair a cut on the lower lip, Knowing where these points are is absolutely paramount.
Makes sense. But doing these nerve blocks isn't completely without risk, is it? Particularly that middle one, the infraorbital.
That's a really critical point to bring up. Yes, because the infraorbital foramen is directly below the orbit. If a practitioner uses too much pressure or maybe directs the needle slightly too superiorly when trying that block.
The anesthetic could go into the eye socket.
Exactly. The fluid can enter the orbit, and the risk there is temporary paralysis of the extraocular muscles, the muscles that move the eye. This can lead to double vision or diplopia. It's usually temporary, but certainly an unwanted complication.
Definitely something to avoid.
Uh-huh.
Okay, we've mapped the front. Let's shift our view now, laterally and then posteriorly. Looking at the lateral aspect of the cranium, original page 1294, the focus here seems to shift more towards maybe mechanical vulnerability.
That's a good way to put it. The lateral wall is dominated by the temporal fossa. This is that shallow sort of fan-shaped depression where the large temporalis muscle sits. You can feel it bulge when you clench your jaw.
Right.
The boundaries are the superior and inferior temporal lines. But the real danger zone on this lateral aspect, the point everyone learns about in trauma, is the pudilarium.
Oh, yes, the Polarian. You hear that word a lot in emergency medicine lectures. Can you describe what it is and exactly why it's considered such a weak spot?
Sure. The pudilarium isn't a bone itself, it's a craniometric point. It's usually marked by an H-shaped pattern of sutures where 4 different skull bones meet. The greater wing of the sphenoid, the squamous part of the temporal bone, the frontal bone, and the parietal bone.
4 bones meeting. Sounds complex.
It is. And crucially, in this region, the bones tend to thin out considerably. This convergence of thin bones makes it structurally the weakest part of the entire lateral wall of the skull.
And the clinical catastrophe isn't just the fracture itself, but what lies directly underneath.
Precisely. Deep to the polarium, running in a groove on the inner surface of the bone, is the anterior branch of the middle meningeal artery, the MMA. So a hard blow to the side of the head, think a baseball bat, a fall onto a hard surface, even sometimes a well-aimed punch, can easily fracture the thin bone at the pudilarium. Because the MMA runs within the dura mater, the outer covering of the brain, rupturing this artery leads to bleeding outside the dura but inside the skull.
Which is an epidural hematoma.
Exactly, an epidural hematoma. And because this is arterial blood, it's under high pressure. The hematoma expands very rapidly, compressing the underlying temporal lobe of the brain. If it's not diagnosed and surgically evacuated extremely quickly, it can cause herniation and death. It's a classic example of a seemingly minor external impact leading to a devastating internal injury.
Truly terrifying. That convergence of thin bone and a major artery. Okay, let's move around to the very back now. Let's examine the occipital aspect, the posterior view, or the occiput as the book calls it. Page 1295.
Right, the occiput. It's that large, convex, sort of rounded area at the back, formed mainly by parts of the parietal bones, the occipital bone itself, and parts of the temporal bones. The primary landmark you can usually feel back there is the external occipital protuberance.
That bump at the back of your head.
Yeah, exactly. It's usually palpable, though sometimes it can be less conspicuous, especially in females. The very tip of that protuberance has a formal craniometric name.
The inion.
The inion, okay. And descending vertically downwards from that protuberance in the midline is a ridge called the external occipital crest. This crest is important because it's the attachment point for the ligamentum nuchae, a big ligament in the back of the neck.
And that crest leads us down towards...
It guides us down towards the single largest opening in the entire cranium, the massive foramen magnum.
The great hole. We mentioned it briefly before, but let's pause here. Its significance really can't be overstated, can it? Page 1295 again.
Absolutely not. It is the critical structural link, the nexus between the head and the spinal column. The foramen magnum's primary role is to transmit the spinal cord, which, as soon as it passes up through the foramen into the skull, becomes the medulla oblongata, the lowest part of the brainstem. It also transmits the meninges covering the cord.
But it's not just the spinal cord, right? Other crucial things pass through.
Definitely. It also allows the paired vertebral arteries to enter the cranium. These arteries are major suppliers of blood to the brain, and it provides passage for the spinal roots of the accessory nerve, CNXI, which actually ascend from the upper cervical spine up through the foramen magnum before joining the cranial portion of the nerve and exiting elsewhere.
Wow. So it's a gateway for the nervous system connection, major blood supply, and even parts of a cranial nerve, critical structure. Now let's look at the very top of the head, the roof, or the calvaria, page 1296.
The calvaria, or skull cap. This superior view is where we see the clearest examples of those fibrous joints we call sutures. These are these interlocking, mostly immovable joints that separate the major flat bones of the skull, the frontal bone anteriorly, the two parietal bones in the middle, and the occipital bone posteriorly.
And the junctions of these sutures create specific landmarks, craniometric points that are important.
Yes, two key ones up top. Anteriorly, where the coronal suture, which runs side to side, intersects the sagittal suture running front to back in the midline, that point is called the bregma.
Bregma, okay.
And then posteriorly, where that same sagittal suture meets the two lambdoid sutures, which separate the parietal bones from the occipital bone, that junction point is called the lambda.
Bregma anteriorly, lambda posteriorly. What's the immediate clinical relevance of knowing these specific points on the adult skull?
Well, primarily, they correspond directly to the locations of the major soft spots in a baby's head, the anterior and posterior fontanelles. Understanding exactly where bregma and lambda are in the adult helps pediatricians know precisely where to palpate those fontanelles in an infant to assess things like hydration and intracranial pressure.
Ah, okay. A direct link to pediatric assessment. Excellent. Now, let's imagine we take the skull and flip it completely over. We're examining the external cranial base, page 1297. This inferior view looks, well, chaotic. It's a landscape of bony ridges, holes, processes.
It is definitely a dense map down there, lots of entrances and exits. Anteriorly, you can see the hard palate forming the roof of the mouth, and just behind that, the openings into the nasal cavity, the cavani. But most of the external base, particularly posteriorly, is dominated by structures passing between the cranial cavity and the neck. And again, centrally, the massive foramen magnum dominates the view.
Looking at this base from below, before we even think about the inside, what are some really prominent features that signal the internal complexity we're about to find?
Well, you can see the entrance to the carotid canal, located in the petrous part of the temporal bone. It's usually a somewhat jagged opening. This is the entry point for the absolutely crucial internal carotid artery, ICA, bringing blood to the brain. It marks the beginning of the ICA's rather tortuous journey through the skull base.
Okay, the carotid canal. And near the foramen magnum, we see the smooth bumps where the skull sits on the first vertebra, the occipital condyles. And just above those, a canal related to tongue movement.
Yes, exactly. Superior to the anterolateral margin of the foramen magnum, you'll find the hypoglossal canal. This transmits the hypoglossal nerve, cranial nerve 12, which is the motor nerve supplying nearly all the muscles of the tongue. Its position makes sense. It exits the brainstem and immediately dives down to control those complex movements needed for speech and swallowing.
Makes sense. The base is also where we can see from the outside those foramen we mentioned earlier related to the trigeminal nerve branches like foramen ovale and the tiny foramen spinosum.
Yes, you can spot them inferiorly. They definitely foreshadow the complex landscape we'll find on the internal floor of the cranial cavity.
It really is a structural foundation, isn't it? We often think of the skull protecting the brain from impacts from above or the sides, but this base is providing defense from below, while also being the main conduit for everything entering or leaving the vault.
That's a perfect way to think about it. A heavily fortified base with critical gateways.
Okay, let's do it. Let's take the lid off the skull, metaphorically speaking, and go inside for what you called the main event, the internal cranial base. Pages 1300 to 1305. This is the floor of the neurocranium, divided into those three descending levels, or fossa.
Right. It's really quite an elegant design. The floor isn't flat, it's terraced.
Right.
We move sequentially from the highest, most anterior level, the anterior cranial fossa, down a step to the mid-level platform, the middle cranial fossa, and then down again into the deepest, largest basin, the posterior cranial fossa. Each fossa is beautifully contoured to cradle different parts of the brain.
Let's start at the top then. The anterior cranial fossa. This is the highest level, right up behind the forehead, and it cradles the frontal lobes of the brain. What bones primarily form this shelf?
It's formed predominantly by the orbital plates of the frontal bone. These are the thin plates that also form the roof of the orbits. Then the ethmoid bone sits centrally in the floor, and posteriorly, the boundary is made by the lesser wings and the body of the sphenoid bone.
And centrally, within this fossa, there are two really critical features we need to focus on.
Yes, the crista galli and the cribriform plate of the ethmoid bone. The crista galli is just a sharp, upward projecting crest of bone in the midline that serves as an attachment point for the falx cerebri, part of the dura mater. But flanking it on either side is the cribriform plate.
Cribriform means sieve-like, right. And that name hints at the danger here.
Exactly. The cribriform plate is a very delicate, thin area of bone riddled with tiny little holes, or foramina. These tiny foramina transmit the very fine, thread-like central processes of the olfactory receptor neurons, basically. The fibers of the olfactory nerve, cranial nerve theoris, coming up from the nasal cavity.
So, extremely delicate nerve fibers passing through extremely delicate bone. What happens if there's trauma to the anterior cranial fossa, say a blow to the face or forehead?
Because those olfactory filaments are so fine and fragile, and the cribriform plate is so thin, a significant blunt force trauma, even one that doesn't necessarily cause a massive, obvious fracture, can cause the thin bony plates to shift just slightly.
Shearing the nerves.
Precisely. That movement can shear those delicate nerve filaments as they pass through the cribriform plate. The direct clinical outcome is anosmia, the complete loss of the sense of smell. And unfortunately, this can often be a permanent and quite distressing consequence of facial or head trauma.
Wow, loss of smell from a head injury.
Okay, moving posteriorly and stepping down slightly, we enter the middle cranial fossa. This one's structurally more complex, often described as having a butterfly shape. What forms it and what does it hold?
It's formed primarily by the sphenoid bone and the temporal bones. The central part is the body of the sphenoid, and extending laterally are the greater wings of the sphenoid and the squamous and petrous parts of the temporal bones. It cradles the temporal lobes of the brain.
And the absolute centerpiece here anatomically is that structure called the sella turcica.
Yes, the Turkish saddle. It's this remarkable saddle-shaped depression right in the body of the sphenoid bone. It has a backrest, the dorsum sellae, and a seat, the hypophyseal fossa. And sitting snugly in that seat is the vital pituitary gland.
The master endocrine gland. And this close anatomical relationship leads to a classic clinical scenario involving pituitary tumors, doesn't it?
It certainly does. If the pituitary gland develops a tumor, like an adenoma, it's confined by bone laterally and inferiorly. So as it grows, it tends to expand upwards.
As it expands superiorly, it pushes on the sheet of dura mater that forms the roof of the sella turcica. That's called the diaphragma sellae, causing it to bulge upwards. And lying directly superior to the diaphragma sellae is the optic chiasm.
The optic chiasm, where the optic nerves cross.
Exactly. It's where the nerve fibers from the nasal or medial half of each retina cross over to the opposite side. So this bulging pituitary mass presses up on the center of the chiasm, specifically compressing those crossing fibers.
And compressing those specific fibers leads to a very characteristic type of vision loss.
Yes, because those crossing fibers carry information from the temporal or peripheral visual fields of both eyes. Compressing them centrally results in a loss of peripheral vision in both eyes. The classic pattern is called bitemporal hemianopsia, often described as tunnel vision. This specific visual disturbance can actually be the very first clinical sign that alerts someone to a growing pituitary tumor.
Fascinating link between anatomy and clinical presentation. Now, the middle cranial fossa is also famous for the complex arrangement of holes in its lateral walls, often described as a crescentiformina. What's going through there?
The concentration of critical openings here is just astounding. It transmits virtually all the crucial nerves and vessels heading to the orbit, face, and temporal regions. If we trace the crescent, moving from anterior to posterior, starts just behind the orbit with the superior orbital fissure. Then we hit the foramen rotundum, which transmits the maxillary nerve, CNV2. Immediately posterior and slightly lateral to that is the larger foramen ovale, carrying the big mandibular nerve, CNV3, along with some accessory meningeal vessels.
Rotundum for V2, ovale for V3. And right behind oval is that small but clinically vital hole.
That's the one. The foramen spinosum. Small hole. Big significance. It transmits the middle meningeal artery, the very same artery that, when ruptured by a blow to the perineum externally, causes that dangerous epidural hematoma. Finding foramen spinosum is a key landmark for surgeons needing to control intracranial bleeding. Medial to these, you also see the foramen lacerum, but it's mostly filled with cartilage and living people. The internal carotid artery passes over it, not through it.
Right. It's just an incredible concentration of vital structures passing through this one fossa, truly a testament to anatomy tying function and risk together. Okay, let's descend now to the final, deepest, and largest level, the posterior cranial fossa. What does it house, and what are its main openings?
The posterior fossa is the largest and deepest. It cradles the cerebellum, the pons, and the medulla oblongata, basically, the brainstem and the little brain. Its floor is formed mainly by the occipital bone, with contributions from this sphenoid and temporal bones. Centrally, of course, it's dominated by the massive foramen magnum,
Which we've discussed. But along the boundary between the temporal bone, specifically the petrous part, and the occipital bone, there are two other absolutely crucial openings we need to highlight.
Yes. Let's start with a larger, more irregularly shaped one, the jugular foramen.
Jugular foramen. What passes through here?
This is essentially the brain's primary venous drainage route.
Hmm.
The sigmoid sinus, which is a large channel collecting venous blood from most of the brain, curves down and exits the skull through the jugular foramen. As soon as it exits, it becomes the internal jugular vein, IJV, the major vein draining the head and neck.
So venous drainage. Anything else?
Oh, yes. Critically, it also provides passage for three major cranial nerves: the glossopharyngeal, CNIX, the vagus, CNX, and the accessory, CNSI. These nerves control swallowing, taste, parasympathetic functions throughout the body, voice production, and even shoulder movement via the trapezius muscle. Damage in or around the jugular foramen can have widespread consequences.
Wow. 9x and ileolum, plus the main vein. That's huge. And just anterior and slightly superior to the jugular foramen, there's another important opening.
Yes, within the petrous part of the temporal bone itself, we find the internal acoustic meatus. This is a canal, not just a hole.
Internal acoustic meatus, what does it transmit?
This canal transmits two vital cranial nerves: the facial nerve, CN7, which controls all the muscles of facial expression, plus taste from the anterior tongue and some glandular functions, and the vestibulocochlear nerve, CN8, which carries the sensory information for hearing and balance from the inner ear.
So hearing, balance, and facial movement all travel through this one canal in the temporal bone.
Correct. That's why fractures of the temporal bone or tumors in this area, like an acoustic neuroma, often compromise these functions, leading to hearing loss, vertigo, tinnitus, and potentially paralysis of the muscles on one side of the face.
It is truly remarkable how many critical, life-sustaining functions are funneled through these relatively small openings in the floor of the cranium. It's like a complex wiring cabinet.
That's a great analogy.
But before we dive fully into trauma and clinical correlations, we need to revisit the walls of the cranium itself, the calvaria. You mentioned it's not just a uniform shell. It has structure, variations in thickness.
Exactly. That brings us back to the concept of buttresses, mentioned on page 1305. The bones of the calvaria aren't just solid blocks. They typically consist of two layers of dense, compact bone, the external table and the internal table. And sandwiched between them is a layer of spongy bone called the diploe. This diploe contains red bone marrow and thin-walled diploic veins.
Okay, so it's a sandwich structure. What are the buttresses then?
The buttresses are specific regions where this bony structure, particularly the compact tables, is significantly thickened. They act like architectural pillars or beams within the skull. Their function is to transmit the forces of impact, like from a blow, away from weaker areas and down towards the much stronger, more solid base of the skull.
Like an internal roll cage, designed to redirect impact energy.
Precisely. Think about forces hitting the face. We have a frontonasal buttress running from the stronger part of the frontal bone, down through the medial rim of the orbit, and the side of the nose towards the canine region of the maxilla. This shunts frontal forces posteriorly. Laterally, the zygomatic arch and buttress takes forces hitting the cheek and directs them towards the temporal bone and the skull base.
So the skull is designed to channel forces away from vulnerable spots.
Yes, away from things like the thin orbital floors or the very thin bones we talked about in the temporal region, like near the perineum and the floor of the middle cranial fossa. Understanding this structural reinforcement is absolutely vital when we start looking at how the skull fails under severe trauma.
Perfect transition. Let's move squarely into the clinical context now, starting with those devastating facial injuries known as Lefort fractures. Original page B8.1 in the clinical box.
Right. Lefort fractures aren't minor injuries. These are serious bilateral, horizontal fractures involving the maxillae, essentially separating parts of the facial skeleton from the skull base. They're typically caused by massive, high-impact trauma, think motor vehicle accidents, significant falls.
And they're classified into 3 levels based on the line of fracture and what gets detached. Can you briefly describe those levels?
Sure. Lefort thirst is the lowest level. It's a horizontal fracture that runs above the level of the teeth, separating the entire alveolar process of the maxilla, the hard palate, and all the upper teeth from the rest of the face. You can literally grab the patient's upper jaw and palate, and it will be mobile detached.
That sounds incredibly severe already. Lefort 2 must be worse.
It is. Lefort 2 is often called the pyramidal fracture. The fracture lines run superiorly from the maxilla across the bridge of the nose, through the medial and inferior walls of the orbits, and then back down laterally. This results in the entire central block of the face, the nose, the maxillae, the palate being detached in a sort of pyramid shape from the rest of the cranium.
A pyramidal separation. And the most severe? Lafourth third.
Lafourth 3 represents complete craniofacial separation, or craniofacial disjunction. Here, the fracture lines run horizontally across the highest points, through the orbits, across the nasal bridge, and crucially, posteriorly across the zygomatic arches. This means the entire facial skeleton, including the cheekbones, is completely detached from the neurocranium. This level of trauma is almost always associated with severe underlying brain injuries and carries a very high risk of mortality.
Just devastating injuries. Okay, moving down from the maxillae to the lower jaw. The mandible is a unique bone, and trauma to it often follows a specific pattern, doesn't it? The rule of two for mandibular fractures, page B8.2.
Yes, the rule of two is a useful clinical guideline. It states that because the mandible essentially functions as a rigid ring, trauma rarely results in just one fracture. You almost always find two fracture sites, often on opposite sides of the mandibular arch.
So a blow to one side causes a break there, but also somewhere else. How does that happen?
It's due to the force transmission. A direct blow causes a fracture at the site of impact, naturally. But the force doesn't just dissipate there. It travels along the rigid bony arch of the mandible.
Okay.
And often, the continued pull and torque exerted by the powerful muscles of mastication, like the masseter and temporalis pulling on the intact parts, causes a secondary fracture at a point of weakness, often counterlateral or on the opposite side.
So the second break isn't directly from the initial hit, but from the forces acting after the hit.
Often, yes. Common sites for these secondary indirect fractures are weak points, like the neck of the condyle, just below the jaw joint, or the angle of the mandible. That's why when you see one mandibular fracture on an X-ray, you must diligently search for a second, potentially less obvious one. Failing to stabilize both can lead to poor alignment and healing.
Makes sense. And fractures at the angle have a particular complication related to teeth.
They do. If a fracture occurs at the angle of the mandible, it very frequently involves the socket of the third molar tooth, the wisdom tooth, if it's present. This complicates things because the bone structure around the tooth socket might be weaker, and the presence of the socket itself increases the risk of infection getting into the fracture line and potentially delaying healing.
Right, infection risk. Okay, shifting back up to the neurocranium itself, the skull cap. Let's talk about calvarial fractures, page B8.4. You mentioned the skull's convex shape helps distribute force, but fractures still happen. What are the main types?
The most common type is probably a linear calvarial fracture. This is usually a simple break like a crack that runs through the full thickness of the bone, often radiating away from the point of impact. They might be dangerous if the fracture line crosses over a major blood vessel groove, like where the middle meningeal artery runs.
Like near the Praetorian again.
Exactly. If it crosses a vessel and potentially tears it. But often, if they're not displaced, linear fractures themselves might be relatively benign.
Okay, but then there are types that are much more concerning because they actually push inward or shatter the bone.
Yes, those are the ones that pose a much higher risk to the underlying brain. A depressed fracture occurs when a piece of the fractured bone is pushed inward, below the level of the surrounding skull. This directly compresses and potentially lacerates the underlying brain tissue and meninges. These almost always require surgical intervention to lift the depressed fragment.
And the third type?
That would be a comminuted fracture. This is where the bone is broken into multiple fragments at the site of impact, like a shattered window pane. In both depressed and comminuted fractures, the big danger, apart from direct compression, is that sharp bone fragments can act like secondary missiles, causing further lacerations or contusions to the brain surface. Very high risk for direct brain injury.
Serious stuff. Okay, let's transition now from trauma to development. This is crucial knowledge for anyone dealing with infants and children. Cranial development and fontanelles, page B8.6.
Absolutely. As we touched on earlier, the neonatal cranium is structurally very different from the adults. The bones of the calvaria aren't fused together yet. They are separated by these wide, fibrous, membrane-filled gaps called fontanelles, which most people know as soft spots.
And these soft spots serve a purpose, right? They're not just incomplete bones.
They serve two incredibly important purposes. First, they allow the bony plates of the skull to overlap and deform slightly during the baby's passage through the birth canal. This process is called molding. Second, and perhaps more importantly after birth, they allow for the extremely rapid growth of the brain during infancy and early childhood. The skull needs to expand quickly to accommodate the growing brain.
We mentioned the main ones earlier, the anterior fontanelle at bregma and the posterior fontanelle at lambda. What's their main clinical value after the baby is born?
Palpating the fontanelles is a key part of the infant physical exam. The large, diamond-shaped anterior fontanelle is particularly informative. If you feel it and it seems unusually tense, maybe even bulging outwards,
What does that suggest?
that's a strong indicator of increased intracranial pressure. This could be due to various things like hydrocephalus, excess fluid in the brain, meningitis, infection, or intracranial hemorrhage. Conversely, if the fontanelle feels sunken or depressed below the level of the bone,
Dehydration.
exactly, that's a
Yeah.
key sign of significant dehydration in an infant. So these fontanelles provide a direct, non-invasive window to assess the baby's hydration status and intracranial pressure.
A built-in pressure gauge and fluid level indicator. Remarkable. And they don't stay open forever, right? There's a typical timeline for closure.
That's right, and the timing differs. The posterior fontanelle, the smaller one at the back, lambda, usually closes quite early. It's often closed by 2-3 months, and certainly within the first year of life. The anterior fontanelle, bregma, however, the larger diamond-shaped one, stays open much longer. It typically doesn't fully ossify and close until somewhere between 18 and 24 months of age.
That later closure allows for that big spurt in brain growth in the first couple of years.
Precisely.
But what happens if these sutures fuse too early? That leads to a condition called craniosynostosis, page B8.11.
Yes, craniosynostosis is the premature fusion of one or more of the cranial sutures. It happens in about 1 out of every 2,000 births. When a suture fuses too early, it prevents the skull from expanding perpendicular to that fused line.
So the skull has to grow in other directions instead.
Exactly. The brain is still growing and pushing outwards, so the skull compensates by expanding excessively in directions parallel to the fused suture. This results in characteristic abnormal head shapes, and the specific shape depends entirely on which suture closed prematurely.
Can you give us the main examples described in the text?
The most common type involves premature closure of the sagittal suture, the one running down the midline on top. Since the skull can't expand side to side, it compensates by growing excessively long from front to back. This results in a long, narrow, almost boat-shaped or wedge-shaped head called scaphocephaly.
Scaphocephaly from sagittal closure. What about the coronal suture?
If the coronal suture, running side to side across the top, more anteriorly, closes prematurely, it prevents the skull from expanding forward and backward normally. So the compensation is vertical growth. This leads to a high, tower-like skull shape known as occicephaly or sometimes pterocephaly.
Tower skull. Does this abnormal skull shape, this constraint on bone growth, typically restrict or damage the developing brain itself?
Interestingly, the source material notes that in most cases of isolated craniosynostosis, the premature fusion of the sutures does not significantly impair overall brain development. The primary result is the malformation of the skull shape. There are some complex genetic syndromes where craniosynostosis is associated with other issues, but for the common types, brain development itself is often normal. The text mentions a hypothesis that abnormal forces from the cranial base might disrupt normal suture patterns.
That's an important distinction. The shape is abnormal, but usually not the brain function itself. Okay, we've covered bone structure, trauma, development. Let's finish by looking at the soft tissue layers covering the cranium, specifically the scalp. And the book highlights the notorious scalp danger zone in bleeding, pages 8.24 and 8.34. The scalp has 5 layers, easy to remember, with a mnemonic CLP.
Right. S, skin, C, connective tissue, dense, A, aponeurosis, epicranial, L, loose connective tissue, and P, periosteum, or pericranium. We really need to highlight 2 of these layers where the specific anatomical structure leads directly to potential clinical danger.
Okay, which ones? Let's start with the bleeding. Why do scalp wounds bleed so much?
That comes down to layer 2, the dense connective tissue. The arteries supplying the scalp run within this very tough, fibrous layer.
And how does that dense tissue cause so much bleeding?
When an artery in this layer is cut, the surrounding dense connective tissue physically holds the walls of the artery open. It prevents the vessel from constricting or retracting, which is the normal physiological response to stop bleeding from a cut vessel elsewhere in the body.
So they just keep pumping blood out.
Pretty much.
Yeah.
Add to that the fact that the scalp has an incredibly rich blood supply with many connections, anastomoses, between arteries, and these arteries bleed fiercely from both the cut ends, the proximal end coming from the heart, and the distal end due to backflow from connections. This can lead to surprisingly rapid and significant blood loss from what might seem like a relatively small scalp laceration.
Okay, that explains the bleeding. Now, what about the danger area itself? That's layer 4, the loose connective tissue. Why is this specific layer considered so dangerous, particularly regarding infection?
This layer is exactly what its name implies. Loose areolar tissue. It contains potential spaces. This means that fluid-like blood from a bruise, a subopponeurotic hematoma, or, more worryingly, pus from an infection, can spread extremely easily throughout this entire layer right across the top of the skull.
So infection can spread widely under the scalp.
Yes, very easily. It can't spread down into the neck easily because of the attachments of the epicranial aponeurosis to the bone ridges, but the real danger is that it can spread inward into the cranial cavity itself.
How does it get inside the skull from this loose layer? What's the pathway?
The pathway is through the small valveless emissary veins. These are little veins that pass directly through small foramina holes in the calvareal bones, connecting the veins of the scalp, running into superficial layers, directly to the large venous sinuses located inside the cranium, between the layers of the dura mater.
And because they're valveless.
Because they lack valves, blood can flow in either direction. Normally, they drain blood outwards, but if there's an infection generating pus and pressure in that loose connective tissue layer of the scalp, that infected material can track inwards along these emissary veins directly into the cranial venous sinuses, leading to potentially fatal complications like meningitis, infection of the brain coverings, or thrombophlebitis of the venous sinuses, or even an intracranial abscess. That loose connective tissue layer truly earns its name as the danger area of the scalp due to this direct potential connection for infection to enter the cranial vault.
It's quite a shocking structural vulnerability, really, in an area otherwise designed for maximum protection. That contrasts the complexity and elegance of the bony scaffolding, juxtaposed with these very specific zones of weakness or failure, seems like the key takeaway here.
Absolutely. I think we've completed a really detailed tour of the bony cranium. We've distinguished the neurocranium from the viscerocranium. We charted those three internal cranial fossae, anterior, middle, and posterior, and identified so many critical foramina related to smell, vision, facial sensation, hearing, balance, and the major pathways for nerves and vessels entering and leaving the brain.
And crucially, we didn't just describe the anatomy, we constantly connected it back to clinical reality. We looked at failure mechanisms like the devastating Lafore fractures, the rule of two for mandibular trauma, the significance of fontanelles in infants, the danger of depressed calvareal fractures, and just now, the risks associated with scalp bleeding and infection via those emissary veins.
Right. So now that this bony foundation is comprehensively established, our next deep dive can logically move to the more superficial tissues. We'll be sort of dressing the cranium, covering the soft tissues of the scalp and face in much more detail. And then we'll delve into the crucial membranous coverings that lie directly on the brain itself, the cranial meninges.
Sounds like a plan. But before we wrap up this exploration of the bone, let's leave our listeners with one final thought to mull over. We talked about the skull's buttresses, how they're designed to reinforce against and redirect direct blunt force impacts. So consider this. What kind of force, perhaps a rotational or shearing force, something acting tangentially to the skull rather than straight on, might be most effective at bypassing those bony reinforcements? What kind of force could lead to catastrophic internal brain injury, potentially even if the skull itself remains largely intact?
That's a really important question in head injury biomechanics, something to think about.
Indeed. Thanks for listening to Bookfulness. We'll see you next time.